Recording. My name is Kush Desai. I'm one of the medical directors for the Georgia Colorectal Cancer Control Program. Dr. Islam and I will be serving as co-facilitators for today's TeleECHO session. Just so we can know each other, if you haven't already, you can go ahead and put your name, the name and location of your clinic, and your role at the clinic, as well as your email address in the chat box. Today, I'm presenting from Swainsboro. We have our Swainsboro team with us here today. Everybody wave. And so, and let me go over today's agenda as well. You can do next slide. All right, so we're going to start with introductions. Then we're going to go into the didactic presentation by our expert presenter. Then we're going to go into our case presentation, and we're going to finish with case recommendations and conclusions. Next slide, please. So this is the platform that we're utilizing is called Project ECHO. It's an extension for community healthcare outcomes. Next slide, please. Just some background information. For quality improvement purposes, we're going to be recording this session. While you're, please don't mention any patient health information in our discussions as these sessions are being recorded. Next slide, please. We do collect some data for research and quality improvement purposes. Next slide, please. Just some general Zoom reminders. Remember to mute your microphone when you're not speaking and unmute when you are speaking. Remember to chat, put questions in the chat screen. We do encourage questions, and we do like people to ask questions. So please either do that or raise your hand, and we'll make sure all questions are answered. Please do use your camera if you're able to and your bandwidth can support it. If there are any technical problems, write into the chat box for Samia Ibrahim or Christopher Turner. They're handling all of our IT issues. Next slide, please. All right. Our first presentation is going to be by Dr. Bryan Green. Dr. Green graduated from the University of South Alabama College of Medicine, where he then completed his internal medicine residency. He completed his GI fellowship at Duke University. And in 2005, he began to collaborate with the Center for Colon Cancer Research at the University of South Carolina to create the Colon Cancer Prevention Network in South Carolina to offer free colonoscopies to the uninsured. In his role as president of the Digestive Disease National Coalition, he spends several weeks a year in Washington, D.C. advocating for funding for digestive health. He passionately promotes colon cancer prevention in underserved populations by speaking at regional meetings and encouraging public, private, and academic collaboration. Dr. Green, take it away.
Okay, well, thank you so much for letting me be here. It's so nice to be able to connect with other people that are like-minded and passionate about helping prevent colon cancer. And so we'll go from there. Next slide. Okay, so basically the background is around 2008, we were approached by the Center for Colon Cancer Research at the University of South Carolina. And what the story is they, again, this is the University of South Carolina in Columbia. They're around 2005, 2006, their GI fellowship or GI division kind of broke apart. So, but they had a very extensive colon cancer research center. Okay, but these are mainly PhD types. So, well, how are you going to do research on colon cancer if you don't have the colon cancer cells, the patients, those sort of things? So, I had been very involved in research when I was at Duke. When I got here, got my feet wet in the first few, couple of years, and then I felt like this was a wonderful opportunity for me to be able to use what I had, which is my connection with other surrounding doctors, with the patients, and to be able to participate in some really meaningful research that can really help prevent colon cancer. So what we basically came up with when we started, it was just myself and my four partners. So there was 5 of us, and there was one GI, Dr. Anderson. And what we did is we agreed to do 200 free screening colonoscopies for the uninsured throughout Greenwood County. Well, and it took a little talk. I mean, my partners, we had to, figure out all the nuts and bolts in this thing. And, I'd like to tell you they were just, super excited about this, but, they were not necessarily. They had some hesitation, some reservations, but, I got them to agree to it. That's all right. Let's just do 200. Let's see how it does. And that's how it kind of started off. So the next slide. So as I said, 5 doctors in Greenwood, 2 to 3 doctors in Anderson, and at the Center for Colon Cancer Research at the University of South Carolina. So they handled most of the data collection. Basically, most of our patients were recruited from various free clinics around the area, the public health clinics. They did a lot of the legwork in the sense of setting that up, getting the information from the patients, and they would gather data. Again, they're going to meet the patient first. They're going to take a more extensive history than we might. They're going to talk about were you breastfed, were you not, did you have well water, did you not, did your mom smoke at your house, how many courses of antibiotics they had, looking for all this data. Okay. They also, the patient would give a blood sample, okay, and they'd have to consent to have that used. Obviously some of it would be frozen to in case it needs to be used later. And then when we found the polyp, it was sent, it was analyzed by our pathologist, but it was sent to the University of South Carolina for their pathologist to identify it, stain it, do whatever. But as I tell the patients, I mean, hey, yeah, you don't care where the polyp goes as long as it's not at you anymore. It can go wherever. So it really was just a wonderful way we could all work together. So next slide. All right. So basically, we had 100 patients were screened with 2 cancers were found. Okay. Here are some of the challenges. Okay. The preps were not the greatest. All right. And we realized this, we realized that a lot of our patients could not read. They couldn't even read on the 7th grade level. Okay. Transportation were an issue. How are you going to get here for your colonoscopy if your car breaks down, if you can't, have someone to drive you, if the person that drives you doesn't have a driver's license? I mean, we went through it. There was every kind of scenario you can imagine. Okay. No show rate because of all those things weren't great. And my office staff, boy, they were complaining. I mean, they're having to deal with a lot of these things. I mean, again, for me and my partners, they get here and do the colonoscopy, but there's so much that has to go on ahead of that. And so, I'd listen to it. So, we did some good stuff. We found some things. We found a lot of polyps, and we kind of gave us the idea, but we knew we could tweak it a little bit better and we could make it better. Next slide. So in 2010, what we did, we rolled out our patient navigation program. So what we did at that point, now this is of course during the economic crisis, and the government funding was getting cut, and we were able to go to the legislature, and actually they gave us, I guess it was about $250,000 that year. Blue Cross Blue Shield, also state Blue Cross Blue Shield, helped us out with a couple hundred, with 1,000 or so grants. So we got a lot of different help. And I went to the legislature, and again, this is I really wonder, geez, are they going to give us any money? They're trying to cut every program they can. And I went up there and I talked to the legislature. I say, okay, you got the Republicans, you got the Democrats. Okay, most of you can't ever agree on anything. I said, but I bet most of you have a colon, and almost all of your constituents have a colon. All right. And there's no reason, and it's not a Democrat colon or a Republican colon. It isn't a red or a blue colon, it's just a colon. Okay. And none of your patients deserve to get colon cancer. And, it kind of touched their hearts. And so I said, and I'm not asking for this money to give me or any of these other doctors a dime. Basically, all I'm asking for is this money is to pay some nurses, usually, but patient navigators. And they're going to help the patients get to the exam and get it done. So they started off, I guess it was about 3 to 4 nurses. It was kind of throughout different parts of the state. And they would do is they would contact the patients. They go over transportation issues. They go over prep issues, language issues. And it really worked out well. The other thing we did is I really ramped it up, really talked it up at some of our statewide meetings. And I said by hook or by crook or by whatever, I talked with this docs and this, and I kind of, I make light of it. I joke, you go to a meeting, and maybe people have a, cocktail after, at a reception, and I get talking to them, hey, there's this great thing we're doing, and they'd say, oh yeah. I say, well, you'll just agree to do a few. I mean, and this is what I like about it, is that you're not committing yourself to say, oh, well, I'm going to do, 5 a month or 10 a month. I just asked for just a couple. Can you just do a couple a month? Okay. And usually once you can get in, and they'll say, yeah, okay, that sounds good. I said, well, here, what's the name of your office manager here? Who do I need to call? Well, come Monday morning, I'm calling the office manager. I'm saying, hey, I talked to Dr. So-and-so, and he said he wanted to help participate in this program, and da-da-da-da-da. And then I'd have the folks from the Center for Colon Cancer, go talk with them. And the next thing I know, the doc, he knows that the patient's showing up, he's getting screened. And when they see how good it is and how good it makes everyone feel, then I don't think I've had any of them that have then stopped doing it. All it is I gotta get myself in the door, get them to agree to do a few, and after that, it most always they agree to do more than they initially started with. So go to the next slide. So what's happened with the patient navigation? All right, the patients have been some of the most well-informed. I mean, when they come here, they know what they're doing, that their preps have become excellent. I mean, they're better than our average preps, okay? The no-show rate is virtually zero. And these patients really appreciate it. I mean, and that's the part that just touches your heart. I mean, these are the people, these are what I'd call the working poor, okay? These are the people, that when you go to a restaurant, these are people that are bringing your food out. These are people that are probably cooking your food. When you go to a convenience store, these are the people that are doing that. These are the farm workers that are out there driving the tractors, doing the stuff that will work hard every day, but just don't work somewhere that has health insurance. And I mean, and they appreciate it. These are hardworking people. They know what they're getting. They appreciate it. Next slide. So this is my, I kind of touched on this already, but talked it up at the different meetings, and it's amazing as you get, you start it going, the enthusiasm really is contagious. I mean, you get in there and like I said, they see how appreciative the patients are. I'll talk to them about, the other docs. I say, hey, I mean, we've been blessed. Okay. I mean, and how can you give back something? Okay. I mean, well, I go work for Habitat for Humanity. Well, which, I mean, there's nothing against that, but I'm not great at, building things. The poor house would probably fall down if I was trying to build it, but I'm really good at colonoscopy. So I can really, do good. And I tell the docs, this is our special talent that you have. And it means so much, to so many people. All it is just a couple of colonoscopies, an extra 15 minutes out of your day. And what it does for people is just so much. So, and it helps, I think, a lot of the docs, and I had them tell me that, it kind of gets back to why we went into medicine. Really all you're there is just trying to help the patient. You're not worried about this payer status or that payer status or this or that. Nothing to worry about that. You're just truly here to help the people. Next slide. So, when we started our little tiny group, there were 5 of us and then a couple in Anderson. Well, currently we're up to 115 participating clinics. Again, a lot of these are the federally funded clinics. They're the free clinics throughout the state. We're up to 86 gastroenterologists, 19 endoscopy facilities, 5 hospital systems, 12 pathology organizations, 13 anesthesia organizations. And we're still growing. I mean, we're on, COVID, we had to kind of have a little delay there with COVID, I think like everybody did. And immediately after COVID, we kind of didn't ramp back up getting the patients through the system. And we wanted to let the clinics have a little time to get caught up, because I didn't want to burden anybody or burden any of the docs. But, within 6 months after, getting the clinics back going, we were back, people were coming through again. And again, with these pathology organizations, the anesthesia, one of the things we heard, and again, we started this, we would say, well, when I'll talk to the other docs, I'll say, well, yeah, I can do the colonoscopy, but then what are we going to do about the pathology? Or what are we going to do about the anesthesia? Well, I say, hey, I mean, the way I'm kind of, when I talk to the pathology group, again, I've done it with my own pathology group, I've done it with my own anesthesia group. I say, hey, you're making a lot of money off of all these other patients that we're doing, okay? I'm giving my time, my staff's giving their time, and we're not asking a whole lot. And I have been utterly amazed with how willing they are to do that. I mean, I kind of really thought I was going to get some more kickback, but I mean, hesitation, but they have really been, I've got to give them credit. They've stepped up. I think when they see that the physicians willing to give their time, their clinics giving their time, they have really have helped us out a lot. So next slide. So currently, over 3,000 patients screened by colonoscopy. 40% have had adenomatous polyps removed. So our ADR is, very good, 40% for the, which is, well above national average. Numerous cancers have been prevented and found in early stages. And we have saved numerous South Carolina lives. The next slide. All right. So again, what I realized, we're doing great. We're keeping doing what we're doing. We're wide open. We're expanding. We're, but at some point, how can I, from my standpoint, how can I spread that word? How can I expand that? Well, we kind of about 2018, of course, this is just pre-COVID. We really were getting into I was able to speak at a few of the different cancer consortiums, a couple of the roundtables, and really spread the word. There's several other states that are trying to do things. I'm thrilled to talk with you, and I think from what I can hear, there was a lot of enthusiasm in Georgia, and I think it's something that's just, if we can just get the wheels turning, I really think you're going to see, it's just one of those win-win. It's good for everybody. It's just such a great thing. So next slide. So this is basically sort of it. So I mean, that's I'll be glad to take any questions or anything that you have.
Thank you, Dr. Green. That was an excellent presentation. Really interesting work you guys are doing in South Carolina. Does anybody have any questions for Dr. Green? If not, I can actually, so we had one, and then let's see, major obstacle. I think they were asking maybe major obstacles that you might have had to y'all's process or to your work.
Obviously initially the patient navigators. Okay, once we've had that, probably our next thing that we really had to handle, we've had a tougher time with the larger health systems. Okay. I feel like I can, when it's a private practice GI group, when it's a physician-owned practice, I can talk with those docs, and I can, pull at the heartstrings, and I can do that. It's a little tougher with a CEO of a hospital. Okay, it's just they come from they're made from different types. So that has probably been our rougher thing. We have some hospital systems that have, but that is a little bit tougher. So.
All right, yeah, interesting. Let's see.
They got their hands up over there.
Oh, sorry. Yeah, we have some hands up. So we have Dr. Islam has a question, it looks like.
Yeah, Dr. Odiambo was before me.
Oh, sorry. Yep, Odiambo, Dr. Odiambo.
Yes, Dr. Green, thank you so much for the presentation. Your numbers look very good. I just have a question about the fact that we know that the families are also at risk. The family members, they need to be also cautious. So is there any outreach or anything that you do or information that you give to the patient that they can share with their relatives so that they're more, aware of the risk or anything that they need to do for early detection?
Right. Well, absolutely. I mean, these patients get, the ones with polyps, again, they're going to meet back. They're typically going to meet back with the navigator, because the navigator wants to know how things went, how to work, how to improve things. So a lot of that is done at sort of the debriefing, I guess, after the procedure. Again, the navigator is going to talk with them. Do you understand what, you had the polyp? Because now we're getting into the surveillance ones. So say now, it's the people that we took polyps off 5 years ago. Now we're getting them back. So that's sort of a whole new data set that we're going to want to look at. Because again, we want to get those patients back. And when we come back in 5 years, we take up or 3 years, whatever, depending on what it is. The ones with cancers obviously need to come back a lot sooner. So no, that's sort of the post talk they have. With the patients, because we really want these patients to know. And so I think, again, just as they're some of the most educated, patients on why they're having the procedure, I think they're some of the most in the sense of what they, what do I need to do now that I've had polyps, and what do my family members need to do now that I have polyps. So again, the navigators are just, they have the time and the ability to do this. And it's just, I wish I had the time and ability to talk with every patient that much, but I just, if I did that, I wouldn't have time to do the colonoscopy. So, it's wonderful to have that ability.
Thank you for that information. Next question was from Dr. Islam.
Hey, Dr. Green, it's a wonderful presentation. I really appreciate your courage going to the legislation and for asking for resources. That is great, especially that everybody has a colon 1 there is no green or red colon. I appreciate that. Now my question, it's not a really question, but to know, do you have any any stable funding mechanism for the state for your navigation program?
Right. So the first year the Blue Cross Blue Shield was very, gave us that first grant to kind of help us get off the ground. We still have to go to the legislature every year. I mean, I go there every March. I mean, I'm over there. I usually spend 2 days in Columbia every March, and because every year you've got to make sure they fund it again. And you think once it gets in the budget, not necessarily. So you never know. They gave it, I believe it was 250 that first year. The economy got a little better. They went up to 500. We're now at right about 500. I think we may have gotten $1 million now. So I mean, they have actually increased our funding, which has been great. We've been able to, through the Center for Colon Cancer Research, has applied for a few private type grants. Now that's going to be, they'll have to speak more to that exactly which ones. But again, fortunately the state has continued to fund us very well. But like I said, you've got to go there. I mean, I don't know. The squeak wheel gets the grease, I guess. So.
Thank you.
Very good. Thank you. Have another question in the chat box from Tanya Phillips. Is there support for patients who may not live near a GI practice site?
Yeah, this is an excellent question. We have been, there are areas of the state, and again, I guess Georgia would be so considered, have a lot of rural state too. We have some county, we have several counties. We have a group, there's sort of the corridor, where we probably have 4 to 5 counties where there is no GI doctor. There may not be getting any colonoscopy getting done there at all. So that has been rough. What we've had to do, we try not to overload the closest areas. Now, like particularly my practice, we'll handle there's about 5 counties around us that are, rural counties that do not have GI docs. So we'll handle those, okay? So those come to our location, but that's sort of our service area anyway. But then there's some spots that are just so far. So, what we've had to do then, we kind of debated with this about time flies, a couple years ago, we started fit testing in some of our really underserved areas. And there was a lot of, I had a little kickback from some of the GI docs that are participating with us. They said, well, hey, why not you're doing screening colonoscopy? I said, well, we're in areas where we can't, these people are 150 miles from the nearest place they could get a colonoscopy. We can't, and so by doing the fit test, we can better use our resources, our colonoscopy resources. So, but that was a big decision, but that is what we've had to do to be able to still offer screening in some of those very more remote type areas. Again, when the fit's positive, then we can get that, but we have to be careful about not overloading our providers that are at the close to those very underserved areas. And I don't want them just to feel like they're getting overwhelmed. So the fit testing has helped us with that.
Thank you. Yeah, I think that's good information using that fit test. So let me see. It looks like we have time for maybe one more question before we get into the case presentation part. Looks like Teresa Williams is asking, what about follow-up for the fit testing?
Right. So those are obviously they're going to come to once the fit test is positive, then they go into the navigator program. At that point, the navigator is going to, we have, various clinics or GI practices have agreed to see those patients. I do see some from Bamborough County, which is way down there. It's kind of a long story. I have a little bit of a family connection down there. And so now those folks have got to drive. And that, if you know the geography, that's an hour-and-a-half drive up here. But I personally have agreed to see those, not necessarily my whole practice, but again, because of the connection I have. And so I will see those patients. So when those come up positive, they'll come up here. We try to get them again to the closest location we can get without overwhelming the those local providers or that nearest GI doc.
Great. Great information. So we're going now into our, you can do a next slide. So the next section of our presentation is a case presentation. This is going to be 10 minutes, about 10 minutes to 15 minutes for the presentation itself. And then we're going to go into about 5 to 10 minutes for questions. So the title of our presentation is Partnerships to Improve CRC Screening, Stories from Around the State. And specifically the state, meaning the state of Georgia. You can do next slide. We heard a nice presentation about South Carolina. Now we're going to talk a little bit about the state of Georgia and some of the partnerships and some of the activities that are going around all over the state of Georgia. The organizations that are being represented are Unified Healthcare for the Rural and Underserved, which is a nonprofit based in Athens, Georgia. East Georgia Healthcare Center, which is a FQHC based in Swainsboro, Georgia. And Horizons Community Solutions, which is a cancer coalition based in Albany, Georgia. Next slide, please. So our first group of presenters are going to be Cynthia Merchant, who's the CEO of Horizons Community Solutions, and Dr. Jim Hotz, who's the Clinical Service Director for Albany Area Primary Healthcare, which is a FQHC that works closely with Horizons. Jim and Cynthia, you guys can take it away.
Thanks very much. Next slide, please. There you go. And we're going to talk about the fact that this fabulous presentation that Dr. Green just gave us, and once again, thank you for that. Want to let people know that he's figured out how to map a whole state out, which is one of our goals. But to let folks know that there are also people that feel just like him, gastroenterologists just like him in Georgia, but nobody's had the vision to pull it to the whole state like he has. So next slide. So this is our area that we deliver our services in, Southwest Georgia. And you can go to the next slide. And our Horizons, that's where it covers, which is a regional cancer coalition. The red areas are the two Georgias. These are the poor areas of Georgia where you have all the bad adverse social determinants. And part of our cancer screening programs are in the east part of the state, where the reds are, and where we are, that white area is in Southwest Georgia. It's the fourth poorest congressional district in the country. Next slide. And here's the problem we face as we started to get into colon cancer screening 10 years after the first studies coming out that it was conclusive that you could make a difference. We had a student working with us from Mercer. They had to do a community science project. And we had to go through all of our paper charts and say, what is our screening rate? So, you know, we think we do a good job. Well, in our chart, our compliance rate was 12%. We said, well, let's do something about it. Let's do a telephone reminder. We got to 19%. And she did an interesting fact in that study. She found without health insurance, it was 0%. If you had no health insurance, you never got through that front door of the GI practice, even though we referred them. We then did physician reminders and patient reminders, got to 29%. And then we did, in our chart, we had a paper reminder so you could check off, and those who used it got to 46%. So what we learned is provider reminders are important, patient reminders can move the dart. We're not as good as we thought we were. And if you had no money in the report, it was 0. Next slide, please. So what do we do with the uninsured? Well, the idea is to leverage our relationships. Now, I had worked in the hospital for 30 years with the GI guys. They saved my butt a number of times with GI bleeders. I also was able to help them out. You know, they got a DKA and a GI bleeder. I took care of it. So as a practicing internist, I developed a very close relationship and realized they're good guys. They want to help. They were unaware of the fact that their front office provided or presented this roadblock. So we had a meeting with them. You know, this was kind of doc to doc talking, saying, is this the world you want to live in? Is this what you want your practice to be? And they turned around and said, I said, can you give us one a month? And they said, no, we can go beyond one a month. We'll give you one a week. I said, well, that's great. That's 50 of them. And he says, no, there's 6 in the group. We all want to do it. So they gave us 300 free colonoscopies. And later they came back and said, we can do 500. And when we asked them, you know, why are you doing this? The same thing Dr. Green said. He said, that's why we went to medical school. We later, as their group joined the hospital and was purchased by the hospital, part of their takeover agreement was, we want to continue doing this. So what we have found, at least in one pocket of the state, brokering on that relationship that you heard Dr. Green say was so important, we're able to get this done as well. Next slide. So what we have found when we sat down with our CEO of our hospital system, and Dr. Green said just how difficult it was, Well, I happen to be chairman of the board of the hospital, so I had an ability to sit down with them and have a relationship. So brokering relationships, like you can see Dr. Green doing in his state's important. And finally, Dr. Joel Warnick, the CEO, said, you know, we have an open emergency room. When they get cancer, we get them anyway. We get stage 4 disease. If they're uninsured, we take it on the chin. You know, we got to go upstream. You know, it's not enough to fish people out of the river when they're drowning. Let's go upstream and find out why they're falling in the water to begin with. And that was his analogy. And he presented this, and we got an award at the National Colorectal Roundtable also. And he showed this slide. So, you know, that relationship is important. The will is there, but once you got the door open, you better use it. As you heard from Dr. Green, nothing's worse than having an open endoscopy slide and not used, and that will turn them off right away. So we're going to go next to Cynthia, and around me is our team of navigators. I'm at Horizons here, and around me is our team of navigators, the people that do that hard job of getting there. And so I'm going to turn it over to Cynthia Merchant, and she's the CEO of Horizons, who's our navigating team.
Thank you, Dr. Hotz. It does make me a little nervous doing this presentation in front of all those professional navigators, but I'll do my best to share with you what we've got going on. Well, Horizons, which changed its name about 5 years ago, was originally called the Cancer Coalition of South Georgia, and we're now Horizons, the Cancer Coalition of South Georgia, to really emphasize that our focus has and always will be cancer. Our patient navigation program is our backbone of who we are and what we do. We don't just navigate colon cancer, we navigate other cancers as well. But we have found that once the door is opened, and Dr. Green, that is why it's so very important to have that partnership and connectivity with the physicians and the health systems and so forth, because once we have the door open, then we have to ensure that that patient shows up with a good bowel prep. And we've been able to do that. That has been not only show up, but show up with that good bowel prep. You have to have a partnership, development and maintenance, staff training and supervision, financial support, quality assurance, data collection, and evaluation. I will say that the CDC puts you to the test on your data collection and evaluation of your program, which has been one of the rewarding things for our organization to be included in that program. Next slide. So the collaborative model distributes responsibilities to improve care. You can't do it alone. I mean, Dr. Green, the first thing you realized was that navigation was going to be essential to connect all the dots and to get the patients. It's one thing to give them away, but it's another to get them to come and take the test or have the screening and so forth. So what the coalition does is we collaborate with our FQHC. Dr. Hotz's clinics have been working with us for more than 15 years in navigating their patients. And we also have worked with a number of Phoebe clinics and other clinics in Southwest Georgia that are serving as medical homes and patient recruitment channels. We do not order tests, so we are the navigator, and they all go through their primary care physician group that we work with and have an agreement with. We work with GI practices, endoscopy centers, and so forth. We have an outstanding relationship with our health system, with Phoebe in Albany, which happens to employ the gastroenterologist and have a wonderful GI practice in our city. And unlike probably in South Carolina, some of our health systems serve multiple counties. So we've got a broader range with that association. And then we also have partnerships with a few other health systems in the south part of Georgia. So it's important to not only have the GI, the primary care doctor, navigation, but you've got all these other pieces that fit in, because once a patient is found to have colon cancer, your job's not over. So we have to continue to collaborate throughout the entire process and navigate the patient through that. Next slide. Role of the health navigator. This would take several slides to really share with you where their job begins and where it ends, because there are so many different things that come up within their job and their role. It really depends on what the that specific patient's needs are. But one of the things that we do is we determine and really qualify the patient for the right test to help, just to go back and check and see if there's a reason why they're going straight to a colonoscopy when they haven't had a fit. If they're an uninsured or underinsured patient, that is our program's requirement for working with groups, is that fit first is always best for our patients that are working in uninsured and underinsured areas, because that way we can cut the cost of colonoscopies and only do those that are truly needed when we have a positive fit. We also provide reminders, provide recalls for our patients that have had a previous test with us, so that they had a fit a year ago, then they're going to hear from us in a year. Reduce the program cost by having medical clearance rather than GI. They are not required to go to their GI now for these patients that are navigated by us, because they take that from the primary care provider. Patients, we provide patient navigation assistance with one-on-one patient education. We arrange their appointments for their colonoscopy. We work with them on all their follow-up tests, schedule and navigate mammograms for those patients as well. We figure while we have them, we might as well check to see if they've had their mammogram. We assist with financial barriers. What started off as really a transportation program has really, we were really looking at financial barriers. So we were able to work with Dr. Hotz for the number of free colonoscopies, and then utilize our state funding for fits for all of our patients, so that we could make sure that the financial finances were not a barrier. But we found that later on, as we've worked in this program for so many years now, it was a need for us to have more than that, more than just a transportation program, which we use a gas card for our patients, but we also provide some bowel prep supplies. We have Spanish speaking navigators, so we are able to communicate with patients from with a language barrier for that particular language, and we'll see if we need to add on to that. But that has been very helpful for Aisha to be able to talk with the patients in Spanish. We conduct appointment reminders, and we reinforce the instructions that they've gotten for their colonoscopy preparation. I know, Dr. Green, you understand they don't always hear everything you say when they come in for their appointment, and sometimes we have to go back and work with them on exactly what they should and shouldn't do to prep for their colonoscopy. When surgery is needed, follow-up surgery is needed, we remind them and walk through them and link them with the hospital financial services. One key thing that we provide is we work with the patients to navigate through that financial assistance. It can be hard enough to get them to do the fit or the colonoscopy, but to have to go through the financial program and qualify is something that we've been able to help a lot with. Next slide. Data collection and evaluation and feedback is a very important part of our role. It is something that gives us, not only tells us where we've been and where we are and if we've improved, if there are areas that we need to improve upon, but it also gives us a real good way to work with our physicians to help them understand their screening rate. And so in their group, how are they doing compared to their other physicians within the group? Or how do you want the whole group? What are you going to set for your goal for your screening percentage? We ensure that the medical records transfer. One of the most important things that we have found that we have to be able to do an excellent job of navigation is we have to have access to the physician's medical record, to the GI medical record, and to the, we also get results back from the lab through our health system. And we also have access to the health system's electronic medical record. So that is key for us to really make sure that everything that we do is communicated to all of the caregivers, and that we're able to have real-time access to the information that's going on with that patient. We contact our patients that we probably get a little tired of hearing from us. I'm sure they don't, but we make a lot of contact with the patients. And sometimes that is very difficult because patients in our rural area that's uninsured have they change phone numbers or drop their phone number quite frequently. So we have a hard time keeping up with that, but that's how we work with our primary care physicians to make sure that we have up to date as much as we can for contact with our patients. Next slide. So the outcomes, these are old numbers, but we've been around a long time. The program outcomes between about the same days, Dr. Green, between 2008 to June 16, you'll see a large number of colonoscopies at that time, 3,200 screenings with 2,760 colonoscopies and a low number of fits. That has flip-flopped dramatically. So we now have considerably more fits than we do colonoscopies. But at that time, we had detected 16 cancers and treatment. Approximately 35% of all the colonoscopy patients that had polyps removed, and our patient no-show rate was 2%. Now that's something that physicians like to hear. No sense in booking an appointment on your book and having someone not show up. And when we're getting it for free, we're making sure that we get there. And then that the bowel prep is adequate, good, or excellent. And our percentage is 96%, or was at that time, and is, I'm sure, still in that number. Next slide.
Okay, so we go to next steps. So this is one isolated part in Georgia. You're going to hear from other ones where it worked. You've seen a whole state that Dr. Green put together. So we brought Dr. Green and he presented the Georgia Gastroenterologic and Endoscopic Society. This was doc to doc, GI to GI, September 24th. This is their big state society. Multiple groups came forward, said they were interested in following the path of Dr. Green. We realized that navigation was key, and we said we're going to try to figure a way to navigate throughout the state. I then presented to the Georgia Primary Care Association on the 28th and said, we got some people willing to, it's almost like dating, we got willing to date, you guys have the needs, let's do this matching process. So right now, many clinics were interested in matching. The Georgia PCA also said they'd be willing to help support Horizons to take this TEFLONC navigation and to maybe expand it through the state. Horizons is already doing it on the east part of the state. So that's the opportunity we have, the next step. You're going to see later in the slide, if you're on the call and you want to participate in this, the Georgia Colorectal Roundtable has a branch called the Access Branch. And Dr. Amin, my good buddy Ravi Amin here, is working with this program. And all you got to do is email Ravi and he'll connect you in to the Access to see how you could get involved in this matching game. Next slide. So in summary, care coordination is important. It can be done. I think we can go statewide. It's hard to sit here and let South Carolina beat us in anything, but they're beating us in this one because of the tremendous leadership of Dr. Green. So you want to get involved. Dr. Amin here, just contact him and he can make certain that you get involved with this group. And now we'll turn that over to the next presenter.
All right, thank you, thank you very much, Dr. Hodson, Cynthia. Our next presenter is Manesh Mehta. He's a gastroenterologist based in Athens, Georgia. He works for the University Cancer and Blood Center, which is a large oncology group in Athens. He's leading up their gastroenterology division. He's with the Unified Healthcare for the Rural and Underserved nonprofit. He's going to tell us a little bit about some of the interesting things that he's done to increase colon cancer screening throughout the state of Georgia.
Thanks, Kush, for the introduction and a great talk by everybody so far. And it, really what Dr. Green's talked about in South Carolina, I've read that paper a few times and really, really impressive. It would be a miracle, and it's clear there's a pathway to get that done in the state of Georgia. Now I'm a board member for UHRU and one of the founding members, which is our nonprofit for based in Athens, Georgia. And our mission, which started back in 2017, was to impact the colon cancer screening rates across the state of Georgia. The reason we identified this as myself, I'm a gastroenterologist, and that's something that's important to me and the type of care that I provide. I was also shocked to see how low the screening rates were across the state, particularly for our underserved citizens. So we started back in 2017, and one of the clinics that's actually on the call was our first clinic was, East Georgia Healthcare Center in Swainsboro. And our goal was basically we created an educational program, and this was modified from one of my prior mentors with the Kentucky Colon Cancer Prevention Project. But ultimately, it's an educational series that I initially presented to the local clinic, especially at Swainsboro. They have many sister clinics. And I think there were almost 100 people in on the call, maybe 80 to 100 in on the call and present, in person for the presentation. And we use it as a very valuable time to educate the different options that they can provide to their patients on colon cancer screening, particularly for those that are underserved and not able to afford colonoscopies. And we really emphasize the utilization of FIT as a economical tool and relatively accurate from sensitivity and specificity standpoint. You're getting your good bang for your buck doing that. Now, we did this type of lecture series across several FQHCs in the state that we targeted that had low screening rates based on publicly available data. And we actually had a very positive response. The clinics appreciated the support, the knowledge, and we also donated these tests and we monitored their screening rates as the year progressed. They had to provide these numbers to us. And what we saw was that these clinics, their screening rates continually upticked, particularly those that had champions in their clinic for screening. If they were dedicated to colon cancer screening, they did even better. And that was really phase one of the project. And our next phase, kind of touching on what Dr. Hotz is talking about, is trying to get our next step, which is getting the colonoscopy part approved once they're FIT positive, especially if they're uninsured or don't have any financial capabilities to get it done. And that has been more of a case-by-case basis, depending on the local relationship of the clinics with their local hospitals and gastroenterologists. And I think that's an evolving scene. For me personally, in Athens, I work at a freestanding surgery center and am able to provide free colonoscopies per my own, will. And that works for me well. But the other gastroenterologists in town, while they're willing to help and say they're willing to do it, it's a little bit more of a challenge given their structure within their practice. And kind of depending on who pulls the levers there, it's a little bit difficult to get everyone on board, which is why I think what they did in South Carolina is extremely, extremely impressive. But that's kind of the nuts and bolts. What we're doing, we're continuing to do this across the state, meeting with various clinics, following up with them, connecting them with gastroenterologists locally, or even in Athens where I am when we work with the Athens Nurses Clinic. And we've had a really positive response, and we do collaborate with Dr. Hotz's group and Horizon as well to kind of pull together resources and see how we can really improve the health of our communities in the state of Georgia.
Thank you very much, Manesh. That was a map of the scope that you just saw before of the Georgia Colon Cancer Prevention Project. All right, next slide, please. Now we're moving over to Swainsboro, Georgia, which is located in the eastern part of the state. If you remember Dr. Hotz's slide, we showed the most disparities in colon cancer. It was actually in the Southwest and the Southeast, and that's exactly where our program, our CDC program, is funded, or is geared towards. Peyton Fry is the practice manager of this organization, of this FQHC. He's going to tell us a little bit about his experience in helping reduce disparities in colon cancer screening.
Thank you. And thank everybody else. I don't know if I'm the last one to speak. Hopefully somebody have questions so I don't have to be the last person y'all hear. But nonetheless, yeah, I don't remember. It's been quite some time since we've lost to South Carolina and Georgia. So that's not real good. But anyways, so let's keep moving that forward. One thing that we worked on early on is partnering. We don't, unlike some of these groups, we're not affiliated with any GI doctors directly. We don't own any. Of them. We're not a hospital group. We're an FQHC. our colorectal cancer screening rates that we track. I mean, obviously that is a big UDS or HRSA care measure. And those numbers, even nationally, are still dragged behind the rest of them, which is quite sad. And then Georgia drags behind the rest of the nation. And then East Georgia drags behind just about everybody except Southwest Georgia. And now we get to drag behind them, I think, because they started a little earlier than we did over in Southeast Georgia. And they've been working on it, like Cynthia said, for 15 good years. So one of our first big hurdles was going to our small rural hospitals because most of our communities, we cover 13 counties in our service area now, very rural Georgia, 6,000 square miles, but 13 counties and all rural. And I think maybe 3 of our counties, maybe 3 have full-time and 2 others have 1 day a week coverage. And so that is, a very small percentage. Obviously, about 1/3 of our counties have any GI specialty there for any significant amount of time. And so underserved would be an understatement as far as specialty care goes. And so we had a pretty big hurdle to climb when we began this project. One of our first things that we had to do is approach those hospitals and see how we could work together. And a few things, if anybody's on the call considering going about a project like this, it all sounds good and great. If you don't own any doctors that can do these services, you've got to have some conversations. So some things that we learned up front, number one, a lot of hospitals actually have colorectal or colonoscopies, and colorectal cancer is one of their indigent programs they're supposed to be meeting. We didn't know that until I went and pitched this, and the CEO, as we were talking, he's like, actually, that's in our plan. We're supposed to meet that. I was like, really? And so they had to turn in their rates already to get their extra tax dollars that they're able to tap in sometimes. So that did help. One tough thing is in rural Georgia, at least, we have a lot of uninsured. I don't care if you're in an FQHC or you're in a private practice. There's just a lot of uninsured. And so when you pitch to a hospital, a totally different organization, which is just trying to make ends meet, especially pre-COVID when we originally began this, the influx of COVID money obviously made it a lot easier to have these conversations with a couple of the hospitals recently. But when they're looking at their bottom line and you say, look, I'm going to send you these and I'm only going to, and this is how much we'd be willing to pay for those. And you kind of get some scary looks. But one thing we do a good job of here that I learned from Jenny Wren, our longtime CEO, is that stack your agreements and know what agreements you have and how much those agreements may bring or have brought to the organization you're asking for a new agreement from. It's hard to have the foresight of a new agreement that sounds like you may lose money up front, but leverage your past agreements that you're still utilizing. We use our hospitals in our service areas for lots of services that we choose not to offer for various reasons. So know those. Also know your total payer mix. So when we began this project, I believe our 2020 screening numbers, compliance screening numbers overall were about 27%. And so know your non-compliance and know their payer mix. And that's one thing we pitched to those hospitals was, look, we have this partnership. If our providers aren't having to consider and our referral specialists aren't having to consider where to send them depending on insurance and who will take them and who will give them a discount and everything else, and they can just say, hey, our local hospital will take you. No questions asked. I'm going to put a referral in. Somebody from Horizons will give you a call and walk you through this process. Basically, it's no thought from, no more figuring it out from here. And when it made it that simple, that did help. We have seen increases. We obviously have had some hurdles. Would love to sit here and say we've had a 50% increase. We haven't, but I will say since our current numbers, our end of September numbers, this is organization as a whole. Now this grant only covers what, 9 of our 13 counties. The other 4 don't have as many eligible patients. So it's not a big loss. So most of everybody's in there. But if you compare our 2020 numbers to today, that's a 28% increase. And just our 2022 numbers compared to end of 2021 is a 16% increase or a 5 basis point increase. We're up at north of 35% now, which is great. We have implemented some new actions, order sets, reminders, re-educated providers, re-educated some new staff. Sable's added on some new agreements with the help of Dr. Desai. We brought in 2 new hospitals. Now we have 3 total hospital agreements for discounted services that we pay. Horizons does offer gift cards or gas cards if they're needed. Our providers have been reinvigorated the last few months. I think during COVID, obviously, there's a lot going on. It's hard to add a whole nother thing, especially if you're sweating outside, having to see the patient outside sometimes. To also remember, hey, here's this fit test, take it home and, do your business. That was just a whole nother thing, and that was struggle, but we have reinvigorated that over the last 6 months, and we've seen a dramatic impact. Just August compared to September, we've gone up 2.5 basis points. So, we're back on the move. Adding those hospitals have helped. But one thing I will say is, leveraging agreements across the board and opening this up and seeing those successes and talking with the hospital and those providers and those specialists, and they like it. They don't like it when somebody says we can't give away services. Not give away, but we can't do these services for people truly in need. And so when you're able to see those successes, it really helps across the board. And a lot of these doors are already open. Just got to walk through them. And, we're in small communities. It's not a hard approach. See somebody at the restaurant and say, hey, not at the restaurant, but hey, can we talk about colonoscopy sometimes? And it seems to work out, the partnership with Horizons and with the entire group, Sable's group, and our provider teams buying in can make a difference. We've seen that just over the last few months, especially with kind of pumping a little extra gas into our efforts. So we're excited about it. Thank you.
Yeah, great. Yeah, thank you, Peyton. And I agree, you guys have been working really hard and the numbers show. So, all right, we don't have time for Q&A. Next slide, please. All right, so if everybody could just use your phone and scan the QR code, this will have a survey, a post-session survey. This will help improve our sessions and give you guys content that's maybe more helpful and relevant. So please do take this survey. That'll really help us make these sessions more informative for our participants. But that's it for this session today. Our next one's going to be Wednesday, December 7th. We'll be sending out reminders and flyers for that soon. And thanks for all of our presenters as well. So everybody can please take the survey and then log off. Thank you, everybody.